assistente aqui da Divisão de Neurocirurgia do Hospital das Clínicas da Faculdade de Medicina de São Paulo, e nós teremos como membros dessa banca, eu que sou o Manuel Jacobson Teixeira, que sou aqui do Hospital das Clínicas, o professor Xavier FMUSP e o doutor Rogério Adas Aires de Oliveira, que vão fazer a arguição, e o candidato terá a oportunidade também de 30 a 40 minutos de responder as questões formuladas pela banca. O doutor Daniel tem a palavra. Obrigado.
Bom dia a todos. Eu queria, como o professor Manuel falou, dar as boas-vindas a vocês que estão acompanhando, seja online pelo link do YouTube, seja presencialmente, a defesa de tese de doutoramento, doutor. Tá dando para ouvir, Hugo?
Assim, Daniel.
Tá bom. Doutor Hugo Sterman Neto, a gente vai passar para a apresentação. O professor Manuel já mencionou os membros da banca, que é o próprio professor Manuel, eu que sou o presidente da banca, o professor Manuel Jacobson Teixeira, claro. Eu vou depois falar de cada um dos membros quando a gente for fazer a arguição. Eu que sou o Daniel Sempre de Andrade, que sou o coordenador, o professor Rogério Adas e o professor Xavier FMUSP, que está acompanhando a gente da França, é um examinador externo, ele é professor, livre docente e chefe de serviço em Clermont-Ferrand, em Auvergne, na França, e tem bastante experiência com dor, também vai participar da arguição. A gente vai fazer essa apresentação, uma boa parte em inglês, mas não é obrigatório. Então, se algum membro quiser fazer comentário em português, pode ser em português, pode ser em inglês, a gente pode mudar quantas vezes forem necessárias a língua, mas o Dr. Xavier vai fazer as perguntas em inglês. So, Xavier FMUSP, we are just introducing Hugo Sterman Neto. As I explained to you, he will start with his presentation, and then we will have time for discussion and questions afterwards for each one of the members of the jury board. Okay, Hugo, please.
Okay, just let me put up the presentation. Good morning, everybody. I'll start the presentation of the results of my PhD research project that is entitled Comparative Evaluation of the Effects of Radiofrequency Thermocoagulation and Balloon Compression Neurotomy for Long-Term Pain Control in Patients with Idiopathic Trigeminal Neuralgia. This project was oriented by Professor Daniel Sempre de Andrade. So the summary of this presentation consists of a literature review regarding historical aspects of the disease and medical and surgical treatments. Then patients and methods will be presented, and the results also will be presented. After that, discussion regarding results will be made and conclusions will be drawn. So regarding literature review, trigeminal neuralgia is defined by a shock-like paroxysmal pain attack that is distributed in one or more divisions of the trigeminal nerve. And these pain attacks may be elicited by simple triggers as touching the skin of the face, chewing, shaving, or even brushing your teeth. It affects more commonly women and on the right side. And it's a rare craniofacial painful syndrome that is extremely debilitating. Some points of the etiology and physiopathology that yet not fully understood are known as the demyelinization that is caused by vascular contact on the root entry zone of the trigeminal nerve, emphatic transmission through the nerve, and some research suggests that mutation in the sodium channel can predispose the individuals to the disease. As described in the literature, up to 90% of individuals will initially respond to medication. High evidence in the literature exists for the use of carbamazepine and oxcarbazepine, although some low evidence alternatives exist as phenytoin, lamotrigine, and baclofen. Despite this initial response, half of the individuals in their natural history will eventually need some surgical procedure, either because of intolerable medical side effects or unable to control pain. These procedures are divided in two major types, as non-ablative procedures as microvascular decompression, and ablative procedures as balloon compression neurotomy and radio frequency thermocoagulation. Other ablative procedures exist as gamma knife surgery and glycerol rhizolysis. All these ablative procedures present with different profiles in rates of response of controlling pain, and each one with their side effects. Some historical aspects of trigeminal neuralgia. In the 18th century, it was known as tic douloureux, since patients experiencing pain attacks could present with facial muscle spasm. Later, the description, a more detailed description of the disease by John Fothergill gave name to the disease. And in the 19th century, when a different nerve from facial nerve was discovered, the disease was named trigeminal neuralgia. At that time, it was known that leading hyposthesia to the face inducing nerve injury could lead to pain control, and this could establish the basis of the development of ablative trigeminal neuralgia treatment. Initial medical treatments date from the 17th and 18th century, when different types of substances were used either topically or orally, and given a wide range of toxicity and low rates of pain control. Until the 20th century, where we developed phenytoin and later carbamazepine, where medical treatment would be more effective. The initial description of open surgery to treat trigeminal neuralgia dates from the late 19th century, where a lesioning of the Gasserian ganglion was performed through an intradural approach. Later, a subtemporal extradural ganglionectomy described by Hartley and Krause, and modified later by Cushing in order to prevent cavernous sinus intraoperative lesioning and control bleeding. Both of these procedures, although leading to high rates of pain control, since they were non-selective rhizotomy, presented with whole face anesthesia that could often lead to corneal complications, pain, and motor complications of masticatory muscles. Later, in the beginning of the 20th century, Spiller and Fraser proposed a more selective rhizotomy, the PSR, the partial sensory rhizotomy. And later, the development of a posterior fossa approach by Dandy. And although this technique was not popularized at the time, his publications used to note a intraoperative neurovascular contact, which would be a hallmark finding of the initial physiopathology of the disease. Later in the 20th century, with Peter Janeta relieving this Dandy's technique through the posterior fossa and using a surgical microscope, developed what we now know as the microvascular decompression. And although his publication was done in 1978, this procedure did not become very popular until the end of the 20th century. Percutaneous procedures became possible after the description of the approach to the Gasserian ganglion through the foramen ovale by Hertel in the beginning of the 20th century, where with the aid of X-ray, he could reach, using a needle, the Gasserian ganglion and produce lesioning. Lesioning can be made with various physical and chemical agents. Most commonly used chemical agent was described initially with alcohol by Harris. And despite presenting with transitory relief in pain attacks, this technique presented with major side effects because of the diffusion, sustained diffusion of alcohol, leading to painful complications and multiple cranial nerve paralysis. This would become less toxic with the discovery of glycerol, a less toxic agent, which could be used in the chemoneurolysis and control pain and with less side effects. The use of thermocoagulation inducing lesioning has its first descriptions in the beginning of the 20th century, where some authors used a boviculture to induce lesioning to the ganglion. And since it was a non-controlled thermal lesioning, it could lead to major side effects to the patients. Later in the 20th century, Sweet and Webster developed a more controlled thermal lesioning with the aid of radio frequency and a thermistor using to control temperature. This technique associated with the awakening of the patients during procedure could lead to a less intense lesioning and hyposthesia to the face, and the awakening of the patient could confirm the trigeminal division of interest to induce hyposthesia. And regarding balloon compression, some authors in the 20th century, instead of performing a ganglionectomy, proposed a decompression over the ganglion, the sectioning of the dura. This was known as the gangliolysis, using the Spiller-Fraser approach. Although the rates of skin sensation reduction were slow and there was a high recurrence rate in these patients, some authors described that the probable cause of pain control during gangliolysis was that the Gasserian ganglion was submitted to a mild intraoperative injury when a cottonoid was rubbed to it. And that became the basis of the development of percutaneous balloon compression by Mullen and Lister, who using the percutaneous approach introduced a Fogarty catheter and induced the Gasserian ganglion trauma with the insufflation of the balloon. Some contribution of University of São Paulo is thoroughly described in Dr. Manuel Jacobson's thesis in 1984, the results of ganglionectomy performed by Dr. Portugal and retrogasserian fascicular section by Dr. Tenuto. The history of the classification of TN over the last 20 years has evolved. Currently, trigeminal neuralgia is divided in some groups since 2016. Primary TN is divided in classical or idiopathic TN. They are different in regarding the presence or absence of neurovascular compression on MRI. Also, TN can be classified as secondary trigeminal neuralgia or painful trigeminal neuropathy. The basis of TN diagnosis rely on clinical aspects as depicted on the table on the left. Current International Headache Society uses this clinical criteria for TN. And in order to classify and not diagnose TN in classical or idiopathic trigeminal neuralgia, IHS recommend the use of MRI to investigate neurovascular contact. So the role of MRI in the diagnosis of TN is questionable, and both classical and idiopathic trigeminal neuralgia can be referred as primary, as in non-secondary trigeminal neuralgia. Current data regarding the results of pain control in using balloon compression and radio frequency comprehend a number of retrospective series and only a few prospective, non-comparative, non-randomized trials, which use a variable number of outcomes to measure success. As you can see, follow-up, time to relapse, success rate, and even some papers not reporting outcome. And instruments used to measure these outcomes vary highly, and some papers don't even report the instrument used. And even when they report the instrument used, these instruments are only simple to evaluate a very complex pain syndrome in nature. For example, the most recent comparative study we found is retrospective in nature, with a sample size of 20 individuals divided in balloon compression and radio frequency that evaluated pain relief at 24 months using a very simple scale that it's a numeric rating scale. And although the study was retrospective, it did not find any difference between groups. So clearly, current data shows a literature gap since published data lacks this uniformity of outcomes definitions and lacks the usage of specific instruments to measure this outcome in a very complex pain syndrome. So the objectives of the present study were primarily to evaluate superiority of radiofrequency over balloon compression in trigeminal pain control at 6 months from surgery. And as secondary objectives was to assess pain characteristics, assess mood and quality of life, and assess and evaluate the onset of new forms of pain, as well as recurrency and characteristics of pain. Patients and methods. Individuals, both male and female, 18 years or older, were included between May 2015 and December 2018. Inclusion criteria were diagnosis of primary trigeminal neuralgia, refractory or intolerable medical treatment, pain restricted to second or third trigeminal division, and had no previous surgical treatment. And individuals were excluded if presenting with secondary trigeminal neuralgia or trigeminal neuropathy, pain restricted to the first trigeminal division, refusal to participate in the study, unable to comprehend the questionnaires, or presented with previous surgery or procedure. The study was a randomized prospective trial, comparative head-to-head double-blinded, which distributed individuals in 2 groups, BC, which was balloon compression neurotomy, and RF, radiofrequency thermocoagulation. Randomization was performed in blocks using an online website. And since we did not find or don't exist any data with formal outcomes to calculate a sample size, we chose to use a convenient sample of 60 individuals that would be divided equally in both groups, and also planned an interim analysis whenever 50% of each groups of individuals were enrolled in each group to test significant between groups, interrupt the trial due to futility, or updated the sample size and continued the trial. Study sites used in the present study were the craniofacial pain day clinic where patients were enrolled, the pain neurophysiology center where the pre and post-operative evaluations were performed, and the procedures were done in the surgical suite of Instituto de Psiquiatria. The study evaluation plan is as follows. All individuals were submitted to a baseline evaluation where all the questionnaires were applied. And after the intervention, 5 post-operative assessment appointments were performed in 7, 30, 60, 90, and 180 days after the procedure. Main outcome of the study was assessed at the last appointment using the third item of the BPI questionnaire, which was the worst pain in the last 24 hours. This study was approved in the local ethics committee. Consent form from all individuals were obtained, and the study was registered in the clinical trial repository. Questionnaires used to measure outcomes were mainly the brief pain inventory, which presented the third item as a question and evaluating the worst pain in the last 24 hours using a numeric rating scale that ranged from 0 to 10. And the other questionnaires used were the McGill pain questionnaire short form, the neuropathic pain number 4, the neuropathic pain symptoms inventory, World Health Organization quality of life questionnaire brief form, pain catastrophizing scale, hospital anxiety and depression scale, global impression of change, and medication quantification scale. Blinding of the present study, individuals were allocated to each group, and to them it was only referred to as procedure. Both investigators responsible for applying the questionnaires and data imputation did not have any other role in the study, as the single surgeon who performed all the procedures played no other role in the study. Allocation concealment was done by drawing a sealed envelope and handed to the surgeon inside the surgical suit before the procedure. And to assure blinding, a questionnaire was applied to all individuals. Regarding the procedures, the percutaneous assessment approach to the Gasserian ganglion was performed as described by Neto. These are the anatomical landmarks that were used to approach the Gasserian ganglion. This is a fluoroscopic imaging showing the settlement of the needle. And the anatomical model on the right shows the trajectory of the needle until the Meckel's cave. For the balloon compression procedure, a 4 French Fogarty was used and insufflated with 0.7 milliliters of contrast media until a pear shape appeared in the fluoroscopic image, and the compression was sustained for 2 minutes. For the radiofrequency thermocoagulation, the radionics generated an electrode were used. After reaching the Gasserian ganglion, impedance was measured and motor and sensitive stimulation were performed with the patient awake to confirm the trigeminal division of interest. Lesioning was performed at 70 degrees Celsius for 60 seconds, and the cycle was repeated until needed, until cutaneous anesthesia was obtained. Results of the study are expressed in means and standard deviation, also at odds ratio and confidence interval. Chi-squared and Mann-Whitney used for non-normally distributed variables, and student t-test for normally distributed variables. Significance was set at 5%. Softwares used were Microsoft Excel and IBM SPSS. To test normal distribution of variables, the Kolmogorov-Smirnov test was used. And for the primary outcome, since it was a major outcome of our study, we chose to use a series of generalized Dismasion equations, which is a mathematical model to take account the variations over time of all variables and to check if the variable of interest is not different in groups just by chance. And it takes into account the variations over time in all variables. The sample size update, we used a power of 80% with the same significance level set at 5%. For the missing data, individuals were excluded if attending less than 80% of the appointments, and missing data was treated using the last observation carried forward method. So our results, we had 87 individuals assessed for eligibility. Of those, 54 were excluded for the reasons on the table. For randomization, we had 33 individuals. They were allocated as follows: 18 individuals to the BC group and 15 individuals in the RF group. After the period of 6 months follow-up, 4 individuals failed to attend last appointment in the BC group, and 1 individual failed to attend appointment in the RF group. For the interim analysis, we performed the intention to treat analysis method. So we had available for the interim analysis demographic data of all 33 individuals. As shown in the table, there was no difference between demographic data as expected from the randomization. And baseline characteristics recorded with the use of the questionnaires did also not show any difference between groups. And as for the primary outcome, which was the worst pain in the last 24 hours, clearly the numeric rating scale decreases over time after procedure in both groups, and as a result, but at the last appointment, this difference was not significant between groups. Since we use this generalized Bayesian equations, we first used a threshold of 5, and since we didn't know if the difference was of both groups was above or below 5, we also ran the mathematical model using a threshold of 2, 3, and 7, and did not show any difference between groups also. Regarding secondary outcomes, mood and quality of life did not differ between groups at follow-up. Using the McHugh pain questionnaire, the catastrophizing scale, the World Health Organization quality of life scale, the mood scale, and number and dosage of medications did also not differ between groups. As to pain phenotype regarding the onset of new pain and its features, we found some interesting results. Patients in the first post-operative evaluation using the item number 7 of a specific questionnaire, we found that individuals submitted to radiofrequency presented with less pain attacks than patients submitted to balloon compression, and this difference was significant. And also these individuals submitted to radiofrequency tend to present with more peristaltic symptoms evaluated with the 5th domain of the NPSI questionnaire. And these peristaltic symptoms tend to last for approximately 30 days, and it tends to resolve over time. Regarding the presence of neuropathic pain evaluated with the DN4, the proportion of individuals that scored 4 or more in the questionnaire at the follow-up did not differ between groups. But individuals submitted to balloon compression tend to experience more pain, presenting with a higher total NPSI score at the 4th evaluation, and this difference was significant between BC group and RF group. Regarding temporal features of pain, the proportions did not differ between baseline and at follow-up between groups regarding presence of continuous pain and predominantly paroxysmal pain, although individuals submitted to radiofrequency tend to present more paroxysmal pain in general than individuals submitted to balloon compression. As to the blinding assessment, the questionnaire applied revealed that individuals submitted to radiofrequency tend to refer they experienced more pain during procedure than individuals submitted to balloon compression, and this difference was significant. As to the rest of the questionnaire, the proportions of individuals who guessed the allocation group and guessed it correctly did not differ significantly between groups, which led us to conclude that probably the blinding of the study was preserved. As to the interim analysis, the study of the power of the present study, which evaluated superiority of RF over BC reached 4.7%. And when we recalculate sample size using a power of 80%, we reached a number of almost 1,500 individuals needed per arm to show a difference between both groups. That is approximately 3,000 individuals needed for the trial to be positive in the primary outcome. And we concluded that we needed to interrupt the clinical trial due to futility of because of the number of individuals needed. So the discussion of our results, we clearly did not see any difference between balloon compression and radio frequency in pain control using our instrument of measurement in the follow-up at 6 months. And despite that, we performed the interim analysis, which updated the sample size needed to show any difference between groups. And since we reached the number of 3,000 individuals needed to show any one exists, we decided to halt the clinical trial due to this difference. And nonetheless, this is the first trial to address this main issue in pain research, using a number of questionnaires to evaluate a episodic pain syndrome. Some procedure-related side effects were interestingly found. So these peristaltic symptoms, which in clinical practice we tend to see when individuals are submitted to radiofrequency, they experience some peristaltic symptoms after procedure. We have seen here the quantification. So individuals submitted to RF at the first and second post-operative evaluation presented with more peristaltic symptoms. And individuals submitted to balloon compression presented at the fourth appointment a total and PSI score higher than RF, which led us to conclude that probably some non-paroxysmal pain exists in these individuals. So the discussion regarding which of the procedure is better to control pain, it's of non-importance, since the decision regarding which procedure to offer may rely more on side effects than on the power to control pain. Since the trial showed that there's no difference in controlling pain and there are some procedure-related side effects, this may be more important than the capacity of pain control. Also, technical difference between radiofrequency, since the first one, the individual is awakened during procedure and the other one is done under general anesthesia, are some points that are needed to be talked with the patients. Some ongoing research is currently been doing using quantitative sensory testing and other special facial functions as olfactory, gustatory, and salivatory function to evaluate these procedure-related side effects and to help the clinical decision-making. A major limitation of the study that was the sample size. Only 33 individuals were enrolled, and this is justified since clinical trials in pain are difficult to maintain individuals through a long follow-up. Nonetheless, we could calculate a power of study, the power of the present study during the interim analysis and update the sample size. And since we reached this large number of individuals needed to show any difference between groups, we decided to interrupt the trial. And for example, the largest series ever published in trigeminal neuralgia refers to 1,600 individuals recruited over 25 years. So this shows that since this is a very rare craniofacial syndrome, recruiting this large number of individuals would be impossible and probably futile to prove any difference in pain control, because both procedures seem to be equally effective controlling trigeminal pain. One other limitation that ought to be discussed is the use of imaging to diagnose trigeminal neuralgia. Since we're dealing with a resource-limited setting, Despite the IHS recommendation of the use of MRI for every individual harboring trigeminal neuralgia, we think that using the CT scan to investigate primary and secondary causes may be sufficient. So since we ruled any expanding lesions of the skull base with the use of CT scan, this raises the question whether the simple CT scan is sufficient for individual to diagnose primary trigeminal neuralgia. And to remind the limitations of the present study was the small sample size discussed previously, the possible blinding bias that was evaluated with the questionnaire, and the short follow-up in pain clinical trials. And despite all the limitations, this present study may serve as guidance for future studies. And to conclude the study, our primary outcome, which was evaluated, showed that radio frequencies was not superior to bone compression in controlling pain at 6 months. And as to secondary outcomes, continuous pain was equally present in both groups at follow-up. Mood and quality of life, although decreasing in the follow-up period, did not show any difference between groups. And recurrency and frequency of pain after both procedure was low, despite subjects submitted to radiofrequency tend to present with more prosthetic symptoms short after the intervention, which would resolve over time. As to future perspectives, we have an ongoing research analyzing data to develop a prediction model of response, and using the facial special sensations as salivatory, olfactory, gustatory, and the QST, we tend to use this to predict, to develop a prediction model of response. This is the main publication as resulted from the present study. It was published in the Pain Journal, and we also published another letter. This was a response to a letter to the editor, also published in the Pain Journal. And this concludes our presentation. I would like to thank everyone for their attention and presence. Thank you.
Okay. Thank you. Hugo Sterman Neto presented his results within the appropriate time. I would like to ask the members of the jury board and present them to the audience. So as I briefly mentioned, I'm Daniel Sempre de Andrade. I'm a clinical neurologist, trained in São Paulo in Brazil, worked in the University of São Paulo for a long time. And recently, I'm now working in another department in Denmark, but I'm also still a collaborator and associate. We call it associate, but it's not the same associate professor as elsewhere at the Department of Neurology and the Pain Center. I have the honor to be Hugo's supervisor, and I will present you the members of the board. The first one is Xavier Moisset. Xavier is a clinical neurologist specialized in pain and multiple sclerosis. He has a very important track and with very important studies in pain, and also he's currently professor, full professor at the Clermont-Ferrand University in Auvergne in France, and also works attached to an INSERM unit of research. It's a big pleasure to have you here, Moisset. I'll also ask Rogério Adas, our long-term colleague, friend, and supporter, clinical neurologist, huge experience within the pain field and neurology, along with Professor Manuel Teixeira, one of the first clinical neurologists that introduced me to the world of pain. First time that ever followed a full clinical examination was in the Liga da Dor, League Against Pain, with Professor Manuel Jacobson Teixeira, Dr. Aline, and Rogério Adas. It's a big honor to be here, to have you here, Rogério. Rogério has a very long and groundbreaking line of research on central post-stroke pain. And also Professor Manuel Jacobson Teixeira, our head of the neurosurgery, discipline of neurosurgery, head of the department of neurology, founder of the pain center, probably the neurosurgeon, one of the neurosurgeons in the world with more experience in conducting trigeminal neuralgia, both from the clinical and from the neurosurgical and neuromodulatory approaches, who was a mentor for Rogério, myself, and Hugo. It's a big honor to have you here, Professor. I explained to Xavier how it works. Now we are going to have his comments and questions. And we decided before starting that we are going to follow a dialogue model, where after a group of questions or comments, Hugo will have time to answer back and they can continue as in a dialogue. And also Professor Manuel and Rogério, if you have any comments on a topic that Xavier is mentioning, you're free to take the microphone and also intervene and make comments if you think it's a good idea, or you can just wait for your turn. But I think it's really interesting when we all interact together. So I would just advise, if you think so that it's a good idea, please do so, and we don't need to follow the in-block method. So Xavier, thank you so much for your presence, for your time, for reading the manuscript and the thesis and everything. So welcome to the University of São Paulo and to this board.
Thank you very much for this kind presentation. I want also to thank Hugo to have invited me and to be involved in the evaluation of the thesis manuscripts and to assist to this defense. I was very interested when you published the article in Pain 2 years ago, and so I was very interested also to read the whole manuscript this time. I have mainly comments, but I also have a few questions. So, as you've probably said during your presentation, this is a work that has a major importance in the field, and it has induced a commentary. You've cited the commentary and you replied to it. According to Google Scholar, the paper has already been cited 5 times since its publication last year, so it's really good for a recent paper. As clearly noted in the manuscript and clearly presented during your defense, trigeminal neuralgia is frequent, is debilitating, and the medical treatment is insufficient or poorly tolerated for many patients. So there is a need for neuroablative treatments, and the lesioning techniques had not been compared directly in a properly conducted randomized controlled study before the study you've done. So the aim of the study was clear. It was to compare the efficacy and safety of balloon compression and RF, radiofrequency. But at the end of the introduction, I've got a small problem with what you have written. In the article, you have written that you wanted to assess the superiority of balloon compression over radiofrequency. And in the thesis manuscript, it is written that you have assessed superiority of radiofrequency over balloon compression. So I would like to know which was the exact hypothesis. Was it radiofrequency superior to balloon compression or the contrary? Or should you have simply written to compare the techniques and to look for the more efficient between the two? If you want to answer this first question.
Sure. In the paper, we tend to use as a referral the radio frequency, and we exploited data of balloon compression over radio frequency. But I think we changed it. I don't know the reason for that, but since we use a convenience sample to calculate the sample size, and we did not have any mathematical model to predict a sample, a sample size using a previously published outcome. I don't think it would matter because the design of superiority using a convenient sample size didn't change the way we calculated. We simply estimated 60 individuals and 30 for the interim analysis. I think this was a typo, but it would not impact the result after all because of the way we calculated the sample size.
Sure, there is no impact on the results, but in the way to write it, I think it should have been modified both in the paper published and in the thesis. And in the methods, you have written that the goal was to assess equivalence between arms. So to reject the null hypothesis that the two arms were equivalent was the real goal of your study. I think it should have been written a bit differently.
Yeah, no, I agree. I'll note that down and made the modifications.
Then you should also do a non-inferiority trial to look for cost effectiveness of the two studies if you want to go a bit further. And in the published paper, you speak about the importance of the cost. In the thesis manuscript, you have discarded this part concerning the cost. Is there a reason why you don't speak about the cost anymore? Or do you feel that it can be one thing that can make the choice between balloon compression and RF?
I think for the thesis, it would not bring any importance in the discussions, but I think for international publication, since we are dealing with very different technical issues between balloon compression and radio frequency, I think to point that out, the cost effectiveness of each one, it would be interesting. But I think your idea is very good because to try a non-superiority trial, taking into account the cost effectiveness, since for the radio frequency we tend to spend more, is very interesting. I think we have a major project that was developed. This data used for this thesis is only a part of it. And I think we can extract more results and conclusions from this major project we had, since we use QST and other functions of phase. But I think cost effectiveness is a very interesting thing to evaluate between procedures.
Great. I'm waiting for the other results. Also, in the introduction, I think that there is a point that has been forgotten. You don't speak about radiosurgery. You speak later about gamma knife, but as you know, gamma knife is a registered name, and it's just one part of the techniques that can be used for radiosurgery. In my hospital, we are not using gamma knife, but we are using Novalis, that is based on X-ray and not on gamma ray. But there are the two techniques that can be used for radiosurgery. And I've seen that you've got gamma knife for around 10 years in Brazil, that is the same in France. And now we are mostly developing X-ray with Novalis. Is there a reason why you never speak about Novalis or X-ray treatments? Do you have planned in the future to compare neuroablative lesions with these radiosurgery techniques?
To compare all ablative procedures, but here in Hospital das Clínicas, we don't have a specific equipment to perform highly precise radiosurgery. I'll change the name gamma knife. It's the name we always use in Portuguese, but I see that refers to one equipment. But I don't have any experience with radiosurgery for trigeminal neuralgia. And here in the department, we tend to use more balloon compression and radio frequency. So to gather up data from radiosurgery, we have to evolve another department, and that can be arranged, but I don't know the number of individuals treated here. will ever reach the number of individuals treated with percutaneous procedures.
And it is also more difficult if you compare with radiosurgery to keep the blinding, because there is no procedure and the relief is not immediate. So it's much more difficult to perform such study. But
yeah,
I think it can be a nice project for the future. We won't have enough patients in Clermont-Ferrand. We can work together if you want to.
Sure.
You've said that MRI, that CT scan was sufficient to separate between primary and secondary trigeminal neuralgia. And I cannot agree with that, because I follow many patients with multiple sclerosis, and trigeminal neuralgia can be the first symptom for many years. And with a CT scan, you don't see anything. So you can treat patients saying that they got a primary trigeminal neuralgia if you don't have the MRI. So did you perform an MRI systematically for patients under 50 or under 40, or was it dependent of other things?
For the present study, this was a very long discussion I had with Professor Daniel. When we look at the diagnostic criteria from IHS, it's clear that MRI is only used as a classification tool, not a diagnosis tool. And since we have limited resources here in Hospital das Clínicas, we chose to perform CT scan to rule out expanding lesions of the skull base, rather than to investigate MS in these individuals. But we did not systematically perform the MRI if we had a hypothesis of MS. But since the sample size was very small, and the presentation with trigeminal neuralgia here, I think it's less common than presentations with sensitive and motor deficiencies, we tend to overlook this deficiency in our study and use the CT scan to rule out secondary major causes of TN.
Okay, I understand the reasons, but I think you cannot say that all the patients had primary trigeminal neuralgia without performing the MRI. You've discussed that point.
Yeah.
In the introduction, I have also seen, I think it's on page 4 of the introduction, you have written that facial hypoesthesia can occur in 19% of individuals after radiofrequency. But you said when you presented the methods that hypoesthesia is systematic just after the surgery. And if you test the patient just after surgery, it's even one thing that shows that the thermocoagulation was long enough to have the hypoesthesia. So I don't know what is this prevalence of hypoesthesia. Was it the hypoesthesia after 6 months or 1 year? Can you remember why there is this value in your introduction?
I think this one is one of the issues when we review the literature. None of the sensorial symptoms or physical findings are related with temporarily. So when we see the papers, they only describe facial hypoesthesia, and they do not say that shortly after procedure we found total anesthesia, and after 3 months it was less hypostatic, and after 6 months this was like a definite hypoesthesia. And since we have a whole data using QST over time during the 6 months, probably the next publication will bring some light in regarding this temporal feature of hypoesthesia.
Thanks. Great. After the introduction, you've done in the written manuscript the historical review, and that was very pleasant to read, and again very pleasant to listen today. I've learned many things because I don't know all the history of trigeminal treatment. that will be very nice to read it again before a presentation, trigeminal neuralgia, to look smart. So thank you.
Thank you.
I don't have any comments concerning the results. They are clearly presented, they are complete for me. And in the discussion, I have noted the same points for radiosurgery. It can be nice to say that there is not only gamma ray that can be used, but also X-ray. And again, for multiple sclerosis, that you cannot rule out all these cases, secondary cases, only with a CT scan. So I won't take the 30 minutes for any other comments and questions. I want just to say again that this is a very nice work, and I wish you all the best for your career.
Thank you, Professor Mosse. Thank you.
Very nice. Thank you, Mosse. Now I will have the honor to ask Rogério Adas. Rogério, please.
Good morning, Professor Mosse, Professor Manuel, Professor Daniel, and the candidate Hugo, Sterman, Neto, and all his relatives. Bom dia a todos. I'm starting in English, and then I may switch in case of necessity, okay? As Professor Moses pointed out, this paper is important in the field of surgical treatment of trigeminal neuralgia, and in my opinion, it brings new options of new evaluation. I wouldn't say criteria, but a way of systemizing we'll comment later, it's difficult to evaluate the paroxysmal neuropathic pain. And this, your work brought a new way of seeing this kind of important way of evaluating trigeminal neuralgia. Well, let's start with some comments. Your thesis, Hugo, it's well written. The title is quite clear. You point out the subject of your study in a clear way. Even the method appears with the title. I have some comments on your abstract and on your resume, because they are important. No começo do resumo, você, nas primeiras linhas, né? A neurologia trigeminal, a despeito de conhecidos, há muito tempo, é uma síndrome facial importante. In the abstract, it's nice to introduce one aspect with historical clues, but I would let this some elementos subjetivos, né, que a dor neuropática é fascinante. Eu colocaria no início da sua introdução. Acho que ficaria mais interessante. E todo esse, eu seria mais enxuto, não tem nada errado, Hugo, é apenas uma questão de estilo, nem precisa comentar. I would put this in the beginning of your introduction. E lá eu também apenas uma sugestão, você está começando, você está convidando o leitor a ler a sua tese. Você coloca a despeito, ela é apesar, contudo, né? Eu colocaria os textos de uma forma mais enxuta e colocaria isso na introdução, né? Para atrair o leitor. Existe uma questão, se passou na sua revisão, aqui, o seu outcome primário é análise da pior dor nas últimas 24 horas em 6 meses. E no resumo, escala numérica da dor nas últimas 24 horas, e não a pior dor nas últimas 24 horas. Acho que isso precisava ser corrigido no resumo em português. Aí tem uma questão de tempo. Fora analisado uma análise interina. Tem uma questão de tempo verbal. Mais embaixo, o objetivo primário não apresentou diferença estatisticamente significativa, apenas uma questão de estilo. O objetivo primário não foi observado alterações significativas, tá? Nada que comprometa o conteúdo, mas acho que poderia ficar mais claro nesse sentido. Na introdução, você inicia de forma clara, fazendo um sumário das características clínicas da neurologia trigeminal. Aí você vai para o tratamento clínico, depois você coloca a classificação. O texto ficaria mais fluido se você colocasse a classificação de uma forma direta. É apenas uma sugestão, não é uma coisa que precisa ser comentada. A revisão dos aspectos, ela coloca muito bem a questão. Você fez uma revisão histórica muito interessante do material. O Xavier já colocou esse aspecto, foi muito interessante. E coloca a evolução dos conceitos sobre a neurologia trigeminal. Um ponto que chama a atenção e que eu queria que fosse esclarecido, que é um aspecto que eu não encontrei nem na tese, nem na metodologia e nem no paper. Você pode colocar uma luz, Hugo, sobre could you put a light in this generalized estimation equation? Because it's important, it's on your primary outcome. Which equation was this? I think it should have been cited in the methods. Which equation is this? Okay, you base your primary outcome on this. I believe, from what I understood, it's based on the pain scores and also the variation or semi-scales, but it's not clear. It must have been better explained in your methods. It's my opinion. I haven't found it also in the paper. Would you comment this, please?
Sure. This obviously was consulted to a statistician before we ran the results. Since the primary outcome was of utmost importance, we discussed with a professional statistician if we should run the analysis with simple mathematical models. And he suggested that since the primary outcome was very important, to take into account variations of the other variables through the period. So this is not something that it's named after a formula. It's a method to evaluate the tendency of variations of all variables in between groups and to check if the variation of the variable in interest, as the third item of the BPI questionnaire, varied in parallel with the other variables, or it is not by chance different. What does it mean? If this variable, if the variation of this variable through the period of follow-up follow the tendency of variation of the other variables, or it was different. And the generalized summation equations is a series of complex mathematical formulas that analyze these tendencies, even with non-normally distributed variables and normally distributed variables. I myself don't understand specifically the mathematical formula used, but it's a way to run a series of evaluations. It's a high number of calculations performed in the SPSS software that shows you, that concludes if the variation of a specific variable is follows the variations of the others, or it follows a specific pattern of variation. I don't know if I make myself clear, but more like this.
Okay, anyway, I think that something should have been placed, because it seems like a kind of black box. You don't know where data can come from. In your methods, you discussed in a very clear way the surgical techniques. As a clinician, I learned a lot with your description. I liked it a lot. In your discussion, you brought some issues from the difficulty of evaluating with instruments the paroxysmal pain. Patients with trigeminal neuralgia have paroxysmal and some kind of mixed constant pain. And it's an issue in the clinic, and it's difficult to study, to perform clinical study. The instruments are difficult to evaluate these characteristics. And you made a complete several instruments of neuropathic pain, DM4 and PSI and other. And which was your impression about this issue? Do you think your study brings another way of phenotyping, of viewing the several kinds of neuropathic pain patients? Do you think it will bring another way of studying this kind of patient? Another question, in PSI, had already been used in this subset of patients, trigeminal neuralgia?
So I don't think my study answered questions more than it raises some important questions. As we published the response to the letter to the editor in the Pain Journal, we brought up this issue that all of the published data, they treat simple outcomes, a very complex pain syndrome in nature. So these temporal features, this episodic behavior of trigeminal neuralgia is very difficult to evaluate just simply using a numeric rating scale, or how are you feeling, or are you experiencing any pain, or are you better from the pain? I think they all treated very simply using very simple instruments, a very important outcome. And our study does not bring any answers, but I think raises the question that, are we doing this correctly over the last, 40, 50 years? Or are we treating the outcome of treating trigeminal neuralgia in a very simple manner? And I think we all can agree that we've been treating the outcomes of percutaneous procedures in a very simple way. So I think when you use a numerous of specific questionnaires that evaluate temporal features of pain and symptoms and onset of non-paroxysmal as continuous and peristaltic symptoms, I think you enrich your evaluation and you can conclude better an outcome of your procedure. And I think there are some publications that use some aspects of the NPSI to evaluate trigeminal neuralgia, but I don't recall specific papers right now. But this is a very nice inventory to treat episodic neuropathic pain. It's very simple to use and very simple to understand. And there's a publication here that validated the questionnaire in Portuguese. So it's very simple to use, and I think it should be used more frequently.
Reading your data, I became curious about the secondary outcomes, about the data on psychiatric aspects, depression scale. There's not a common sense, but a general impression that trigeminal neuralgia patients, they differ from other chronic pain patients in terms of being more of having less psychiatric illnesses. And I believe this data is going to be published in another moment. No? Could you make a comments on this, please?
So as we draw the secondary outcomes, we were more interested in the painful aspects of secondary outcomes. And we only applied the mood and quality of life questionnaires to compare not at the baseline with other painful syndromes, but changes over time and difference between groups, which was, since we're performing two different procedures that may impact patients' life differently, we applied these questionnaires to see if we found an objective difference and if this difference impact mood and quality of life. I think the intention to use these questionnaires was to evaluate secondarily the impact of procedure-related side effects and not to compare at the baseline the difference between painful syndromes. But the data, we have the data, we can easily compare to other pain conditions.
Another question on page 49 in the results, we see the proportion of patients satisfied with the procedures, 55% in BC group and 50% in RF group. These levels, it seems to be low comparing to other series that patients treated with surgical options with trigeminal neuralgia, they have higher scores of satisfaction with the procedure. How would you explain this data?
So this is what this answer was the last item of the blinding assessment questionnaire. It's not a questionnaire to evaluate satisfaction. So the questionnaire comprehends 4 items: that pain experienced during procedure, if they could guess which group they were allocated, and if they guessed correctly. And the last question was if you needed to be submitted again to the procedure, if you're willing to. And it's a questionnaire to assess rapidly blinding of the trial. I think the assessment you're referring to is the clinical impression of change.
No, if I'm not mistaken, some other series states about 80 to 90% of satisfaction with the surgery, and from I don't know have the citation, but in general, as a clinician, we see the surgical treatment of trigeminal neuralgia as patients being highly satisfied in general. So it brought my attention, this data. There was some differences in the evaluation of pain data between groups. In V1 and V2, we had an absence of trigeminal paroxysmal pain and more paresthesic symptoms in the RF group, okay? And as times evolved, as time in V3, V4, and V5, the performance of both strategies have changed, okay? And my question is, have this data changed your way of indicate surgery or one or other type of procedure for your ENT patients? Or you couldn't come to?
So this was very interesting because the secondary outcomes findings, they are in concurrence with what we always heard about radio frequency. We tend to submit individuals to radio frequency, and it's common for the next short after the procedure, like 2, 3, 4 weeks, individuals, despite not having any pain attacks, they complain about some prosthetic, some tingling, pins and needles to the face. And despite we always knew about this, our study just proved it. It exists. It's not simply clinical experience. It's a procedure-related effect that is expected to occur, not a unexpected side effect. So, but I don't think this would change anything. I think the clinical decision about which procedure to offer may be presented to the individual alone, and you have to make a decision together with patient and not a proposed one procedure or other. You have to show him the advantages and disadvantages, side effects, capacity of controlling pain, and this may rely on the patient to choose which procedure he prefers or not.
Do you believe that larger group of patients, of subset patients, trigeminal neuralgia with chronic trigeminal, do you believe that phenotyping this kind of different subset of patients could bring more data if you went further in this study? For instance, could you have better data on some em dores paroxísticas ou em dores de caráter mais contínuo? Você acha que traria mais informações?
Eu acho que sim, a gente tem uma quantidade razoável de data usando avaliação quantitativa, sensorial da pele, sensitiva da pele, junto com função olfativa, gustativa, salivatória, que a gente vai aplicar a modelos preditores de resposta baseado em variações concomitantes de impressão de dor, temporalidade de dor, presença de paroxismo e não paroxismo, junto com alterações sensitivas de pele. Então, acho que a gente consegue propor um modelo preditivo de resposta baseado nisso, baseado no perfil do paciente, né? Então, olha, para esse paciente, talvez a radiofrequência seja melhor ou o balão seja melhor.
Ótimo. E antes before finishing my comments, I would like to congratulate you for your, it's an important paper, and I believe it brings some new light in this field and as a model of evaluating this paroxysmal pain. Congratulations. I'd like to make to make a comment about the format of thesis. Your thesis was written in English according to the recent resolution of USP, né? I've checked this, a resolução da Comissão de Pós-Graduação 7493, a partir de 2018. Então, que permite que as teses sejam escritas em português e em inglês. Então, isso que eu vou colocar apenas um comentário que em nada compromete, assim, um comentário pessoal, né? O pensamento, e que não tem a ver com a sua tese, é uma análise desse modelo. Eu queria colocar brevemente uma questão pessoal, uma impressão. O pensamento, posto que, enfim, a universidade é um espaço de livre pensamento, né? O pensamento, a linguagem estrutura raciocínio, a linguagem estrutura estratégias, né? Então, eu sou totalmente de acordo com modelos mistos, em inglês e português, mas escrever na língua materna é importante, e a vasta maioria dos alunos de pós-graduação são Portuguese native speakers, né? Nós falamos o português. Então, eu acho que foi uma decisão equivocada, sobretudo a tese escrita ser colocada em inglês. Tá? Fecha parênteses. Meus parabéns, Hugo, pelo belo trabalho publicado no Pen Journal, um jornal de grande impacto. Você colocou uma pedra, você e todo o grupo colocou uma pedra importante no conhecimento dentro de uma tradição de um grupo que tem publicado bastante, né? O professor Daniel, o professor Manuel, tem uma tradição. O Centro de Dor fica honrado, a gente como colaborador, a gente fica honrado em ver membros do grupo publicando em revistas de primeiro impacto. Então, muito obrigado e parabéns.
Obrigado, doutor Rogério.
I'd like to ask Professor Moisset, are the theses in France written in English?
In France, it's written in French in most of cases, but in English only if there are international reviewers that are planned for the defense. But most of the theses are written in French.
Yeah, I was raising this aspect that there are models. No doubt that the paper is the universal and language is universal scientific language, but the thesis format has a role. It has centuries, and it brings some learning aspects, and it's better dealt with the native language. It's one thing I believe. So, due to the importance of University of São Paulo in our country, I think this is nowadays maybe written in both languages, and I think it was not a good option from the university. Okay, that's why I raised it.
Thank you for translating.
I would like to ask Professor Manuel Jacobson Teixeira to make his comments and critiques and questions. Professor.
Thank you for the invitation. A few comments. The question for you, what way by which by my as neurosurgeon interpret the results. What is your concept about it and the effectiveness?
Desculpe interromper, professor. Não sei se a Larissa está aí, pode ajudar a gente. Está muito baixo, não dá para ouvir o que o senhor está falando. Se alguém puder aumentar o microfone.
Hello?
Hugo?
Eu posso fazer a pergunta? Qual é o seu conceito de eficácia e efetividade? A gente faz um trabalho sobre isso, você definisse, isso é importante no trabalho, você vai comparar dois métodos, eficácia e efetividade. Você começa na sua discussão dizendo que os tratamentos mais efetivos apareceram no fim do século XX. Isso não é verdade. No fim do século XIX, quando se fazia gangliectomia, os resultados eram excelentes quando eficazes. A efetividade era desastrosa.
Eu acho que a eficácia, então, seria... Okay. I think efficacy is a term that refers to a objective evaluation of an aspect, as in which procedure controls pain attacks. If the procedure is successful in controlling pain, it's a efficient one. And effectiveness is the way we can control without being disastrous. As to superheroes, they fight bad guys, but in this process, they destroy a town. So it's not really that effective. I think procedures are highly efficient in controlling pain, but our studies show that the pain control is not something that we have to look for. Instead, we have to look for major side effects, painful complications, mastigatory weakness, and perception of non-continuous pain and presence of prosthetic symptoms that the patient complain and he cannot do his work and daily activities because of this prosthetic symptom. So I think all of them are efficient in controlling pain, but as our study showed, I think when we're dealing with surgical procedures in pain, it is more important to deal with which side effects you're willing to carry on than with the success of the procedure. I think I made a confusion with the terms.
Quanto à eficácia, 100%. Efetividade, 0%. E nós estamos trabalhando, conforme você colocou dentro do seu contexto, no objetivo segundo e terceiro ponto. É muito difícil, e o cirurgião que faz tem que ser muito hábil para fazer isotomia no segundo ponto, com frequência, sem que haja extensão do oprimido. Você pode fazer um trabalho visando a ablação de uma estrutura em que o limite de segurança de menos não informando nada sobre o que aconteceu com o primeiro plano. Quanto ao balão, nós já fizemos estudos de QST, que foram publicados, inclusive são muito citados hoje em dia. A gente já sabe a proteção que existe. Contaminador. Balão é técnico, radiofrequência é arte. São dois modelos diferentes de fazer uma medicina de alta qualidade. você teria condições de comentar que você está trabalhando em cima de uma lâmina de carga. Você não tem condições. É pouco provável que numa das você não tenha extensão. Nós fizemos um modelo de quantificar os resultados da intervenção de 1984, você cita aqui alguma coisa. E lá nós pusemos uma proposta de classificação que foi até comentada no Congresso Europeu de Neurocirurgia, em que nós fazemos um balanço entre a eficácia e as adversidades, quantificando, né? Ela foi de fato seletiva, ela não foi seletiva, o quanto essa seletividade implicou em melhora, sem adversidades de outra natureza, foi feito um balanço. Infelizmente, esse trabalho não foi reproduzido. Recentemente, numa publicação sobre o assunto, um autor were commenting about the side effects of the procedure. Radio frequency is more selective than balloon compression, but the invasion of the hypoesthesia to other branches are very common, despite the selectivity of the radio frequency in relation to the diameter of the fibers. So it's very difficult to put a lesion in the second branch without extension of the lesion to the first or the third branch of the trigeminal nerve. I think this is very important when we quantify the results, not just the efficacy. As I told to you, the best efficacy in trigeminal neuralgia treatment was the ganglectomy, described in the end of the 19th century. No pain, but with deaths and the other motor complications and the other neurological and non-neurological complications. So efficacy is a point, is important, but it's not the whole history. And we are talking about to make the radio frequency rhizotomy is art. Put a balloon is just a technical problem. And based on this concept, when you described the method, you put an observation. I don't agree with your observation. You put the patient under general anesthesia, intubated, and this technique is not very used in Brazil and the other countries. No intubations, especially for percutaneous radiofrequency rhizotomies, with the patient sedated or general anesthesia, short-lasting agents, because you should to wake up the patients during your procedures. So I think that many of our patients were not operated under general and endotracheal intubations first. And the second comment is about the anesthesia. You put here that to control the result, the patient was awake, and the surgeon made a test to get anesthesia over the branch. But this is not the way by which we do radiofrequency procedure. Is analgesia, maybe, but tactile preservation. Can you comment? You wrote here. Oh, sorry. Very sorry.
Não, tá baixo.
So the first question about efficiency and effectiveness, the objective of this present study was to evaluate pain control. We know there are major side effects and skin sensation decrease, and this data is kind computed, and it will be objective of another study. So we test skin sensation with QST and other functions, and will be presented in another publication regarding the alterations in the first trigeminal division when a second trigeminal division was aimed to treat with radio frequency. Regarding, so the present study.
Na página 38, métodos, você põe sensation was tested compared with contralateral side using safe speed between cycles, and this process was repeated until skin anesthesia.
It's a wrong term. It should be analgesia.
Analgesia.
Yeah.
Correct. Because it's wrong.
It will be corrected. Thank you. And the procedure had involvement, performed all procedures. So this is the description he gave to me of what would happen in the surgical suite. It's not common.
Yes, I understand. Well, let's go on. Another question is about the method that you use to evaluate the result. You put the most severe pain during the last 24 hours. When we analyze the period of pain in patients with trigeminal neuralgia without treatment, usually 3 months, more or less, we have a Brazilian questionnaires used in our group and outside the Hospital das Clínicas in Brazil. But in other countries, more or less 2 or 3 months is the period of pain. And the period without pain may last 1 day, 1 week, 1 month, 1 year, 5 years, 10 years. How can you measure the result of our procedure just in 24 hours? It's too short. This doesn't mean anything about the result of our procedure, because it may be just a coincidence of there is a moment without pain naturally, not due to your procedure. I don't like the way by which you collected the results of your procedure about the relief of pain. Maybe just a coincidence. 24 hours doesn't mean anything about trigeminal neuralgia.
So I think this proves again that the evaluation of a complex episodic pain syndrome is very hard to transpose it, to translate it to clinical trials. To use a specific item of one of the questionnaires was arbitrary. We chose to use this one to measure our primary outcome, but we know this is a limitation since trigeminal neuralgia can stay for long periods of refractoriness and don't present with any pain attacks. So probably one of the limitations here is we cannot be sure that the period the patient is not experiencing no pain attacks may be due to chance and not because of our procedure. It's a limitation, but when it's an arbitrary option of the study group, we chose this item.
I think published a very good paper in New England. How was the frequency of your pain in the last 1 minute? Yes, but you could make additional point of view about the evaluation in the last 3 months, last week. What was the frequency of the pain that you have during the last month? Maybe better than 24 hours. For this kind of evaluation, I don't think that these methods are good ones. You can accept because it was the method was applied, it was used for all the patients the same way, no problem about the application, but the quality of the evaluation is very poor, in my point of view. In relation to the, what do you think about the procedure? Percutaneous radiofrequency is difficult to make because it's art. And second one, the patient should be awake during the procedure. Very often, they complain about the pain. And the pain is not a toothache, it's more than a toothache. So very often they complain. It's just a surprise for myself that there was no difference because the balloon, you sleep, you are not awake about what is happening. But in radio frequency, you should awake, you use a needle, it's necessary sometimes to complete the procedure with the patients awake. You will feel some painful, very painful sensation in the face. So I think that the results should be reviewed, my point of view. Another question is about the problems related to this surgery. You made the mentions that the main complications of the balloon compression is bradycardia. No, we have a paper, a thesis published by our group talking about the trigeminal cardiac reflex and the hypertension. Hypertension with brain hemorrhage is a very severe classical complications of the balloon compression. And so you should change your observation in bradycardia. There's no bradycardia. Cardiac abnormalities, other general complications, but not bradycardia may occur, including a cardiac arrest during the procedure. Reversible, usually reversible, but hypertension is another complication. This is why we proposed the use of a trigeminal ganglion block to prevent this complication. Is a thesis of one of our collaborators here. About the way by which you selected your patients. Agora now about the material you have used. Why haven't you tried to divide your patients in two groups, type 1 and type 2 trigeminal neuralgia? We made, when I made my master degree thesis, I didn't use the term type 1, type 2. I use the term idiopathic or classical trigeminal neuralgia and atypical trigeminal neuralgia, mean what presently is named trigeminal type 2. And there was a difference between the results between the first and in the second group. It's just to talk, not to NMR or PET CT or CT, just an observation. Maybe that you can, as you are comparing two methods, you can put more information about the indications of the surgical treatment of trigeminal neuralgia. There are papers about the trigeminal root decompression using this type of classification. Results in type 2 are less expressive than type 1 trigeminal neuralgia. If you have the samples, it's possible to collect the information. You should again make the analysis of the results and try to compare both sides. If you see, or radio frequency is better for type 2. I think it is. And the balloon for the type 1 trigeminal neuralgia. And when you talked about the physiopathology, you talked about the fact currents. There is a question mark about this physiopathology. I wrote at that time, and again, I used in 1985, possible peripheral etiology, possible. Central pathogenesis, 1984. We are 2022. I didn't change my mind. At that time, no knowledge about good information about neurotransmitters, synaptic reorganization, the role of the systems that are modulating the sensory informations about the face. What I think many of the other authors think, if you have a lesion peripherally, as the nuclear complexes of the trigeminal nerve is very big one, this size for a very small space in our body, too many neurons, very small amount of modulatory systems, makes that any lesion in the face, maybe in the touch, the teeth, maybe sometimes in the sinus of the face, if you have a small lesion in this place, or even in the root or in the ganglion, a very small lesion, the differentiation of the small parts of the nuclear complex is a reason for reorganization of the synapses, the sprouting of big or tactile fibers inside the areas where that you are processing the pain sensations in the face. This reorganization of the synapses in the trigeminal nuclear complexes may be the reason of the trigger zones observed in trigeminal neuralgia. Ephasic currents is a doubt about it. In 1938, they described this phenomenon, but it was not confirmed in recent researches about this subject. So it's a central problem. And there is a doubt about the vascular compression. What is the frequency of vascular compression in normal population? And what is the role of the sodium canals abnormality? Because we have papers written by our group about this subject. What is the balance between the compression of the root? I don't think that it is true. And the existence of the abnormality in the sodium canals in this situation.
So I'll begin answering. In experience during procedure, we applied a blinding questionnaire that asked individuals about pain during procedure, and that showed a significant difference between individuals submitted to radiofrequency and balloon compression. So obviously, when you're submitted to radiofrequency, the experience of being awake and sensitive stimulation can generate a lot of anguish. Regarding the hypertension and bradycardia, I'll do the corrections. Mainly, there's the publication by Dr. Chibano. Regarding classification of TN and TN1 and TN2, since we designed a formal clinical trial, we tried to use a more current and more formal classification form. So we tried not to mix old classifications form and try to keep the trial in a very formal way. So since I didn't have no role in the procedures and the surgeon, no role in data imputation, and the investigator applying the questionnaires didn't have any role, so we tried to do it in a very formal way. And individuals enrolled in the day clinic, they were notified to the group as presenting with typical trigeminal symptoms. We try to exclude atypical individuals to keep the trial more simple in evaluating efficiency of the methods regarding just pain attacks. And as to the etiopathogenesis of the disease, yes, we know it's a central issue about reorganization. And this was just a comment about the possibility of peripheral starters. There are some papers that describe this sum of factors. So we tend to know that trigeminal neuralgia is not a simple disease, not as the clinical picture, not with the pathophysiology. So we know it's a sum of factors, the mutation of sodium channels, the demyelinization on the specific root entry zone of the trigeminal nerve, and the specific central changes, they all sum up to present with the changes observed in patients with trigeminal neuralgia. It's just a simple way to say there are some common ground, but they don't explain the whole pathogenesis of the disease. And vascular compression is very common. If you take a pool of normal individuals, you can find up to, I think it's 10% of individuals, some neurovascular conflict. But the IHS clearly states that you must have sinal change in the nerve and deformity and atrophy. There are not just the contact to the vessel, but some deformation of the nerve. But I think the sum of all these factors, they show that this is a very complex, painful syndrome, and not just one factor will explain the causation of the physiopathology.
The necropsy studies showed that 40% of the normal population presented this abnormality, and it may be that the sodium canals or other canals are involved in the occurrence of the disease. So if you have a canalopathy, if you put a second lesion over this nerve that has a congenital abnormality, the patient can get the disease. This may be the reason. But about the classification, if all the classification, no change of the classification during the last 60 years. New names for the same concept. Type 1 means idiopathic, maybe trigeminal neuralgia, or type 2, maybe the atypical one, and so on. But the new classification you put here, and you use it here. I am not finding here, but there is a table. You put till 2000, blah, blah, blah. After you put some classification, and you finish with YASP or Headache International Society, and you put até uma chave, esqueci como fala isso em inglês, continuous and the paroxystic or paroxysmal.
Página 6, professor.
Just the same. You use this table in your thesis. You should use it to classify your patients, because you made a mention to this one. It's just to ask.
It's on page 5, the evolution of classification. So we tried again to keep it simple for the purpose of the trial. I know every type of TN, even classical and idiopathic, both primary, secondary trigeminal neuralgia, and painful trigeminal neuropathy, they all have a sub-item that describe every one of them can present purely paroxysmal or with concomitant continuous pain. One of them more typical than the other. And we try not to use this subtype of classification, but we explore the data regarding presence of a more paroxysmal clinical picture and a more concomitant pain. And we describe the proportions in the results part, because we know the atypical and more continuous pain aspect of the disease may present with poor results regarding percutaneous treatment or every type of treatment at all.
No more comments, but as a thesis, you publish this. Try to uniform the presentation of your references. Some of them as in italic, other ones no italic, and so on. Would be more elegant, the presentation for the archives of the University of São Paulo. This is very easy to repair. And I am very pleased to stay here, make comments about your thesis. Is a subject very important to us, and try to take more information. I think other publications can be done with the material that you have collected, because if you have other parameters recorded, it's easy to take them to make comparisons, maybe other solutions. But try to compare type 1, type 2. I think some contributions are necessary for the percutaneous ones, because for the compression, there are many papers talking about this subject, because they are not the same. I think trigeminal neuralgia is a wide group of diseases with a semi-clinical expression or almost the same clinical expression. This is my point of view. Thank you very much for your invitation, to your Dr. Daniel, to invite me to stay here with you.
So as a last comment, this is a very interesting matter as well. The spectrum of paroxysmal and continuous pain. We have ongoing research to develop a response model based on clinical picture baseline.
Just an observation, as we're talking as friends. When the compression of the trigeminal root was becoming popular around the world, there was an opinion that to the type 1 would be the compression just in the entry zone, meaning the contact between the myelin produced by microglia, oligodendroglia, and the Schwann cells. That's the reason that is not the penetration of the root in the brainstem. And in this situation, type 1, no abnormality, just paroxysm, no continuous pain. And when the compression was placed distally, the lesion should be more a heavy lesion, the differentiation more important, and this is why the burning sensation will happen or perceived by this kind of disease in some patients. And the results, if you have a very big lesion in a nerve, despite the treatment that you performed, you give to the patient, the result should be less than when there is a simple, partial disease in a very delicate region of the peripheral nerve that is the entry zone. So using this methodology that you have using your papers, we know that the balloon produce less problems with the afferent fibers of trigeminal nerves. Radiofrequency, severe lesion in the peripheral nervous system. And if you have a type 2, there is a lesion, a strong lesion, you should make a strong surgery, mean radiofrequency. Maybe type 1 balloon is enough for long-term good results. I have this impression, but you should prove it. If you have the material, go back to the records that you have, try to see if there is possibility to take this information. Very easy, no complex, so few cases, no problem. And good, you have a good doctor helping you, Dr. Daniel.
Professor Daniel, the microphone is yours.
Okay, so I would like to ask the members of the jury board if they have any other comments, if they are satisfied.
No other comments.
Okay, I'll just make a few comments myself. First of all, I would like to thank again all of the jury members to be here. I'd like to thank you for reading so carefully the paper. I would like just to make a few comments. Related to generalized disseminated equations, Hugo was maybe too shy, but he analyzed all the data with classical analytical inferential analysis. And when we, following the pre-established assessments that we were going to perform, we noticed that we had negative results, and that's how it would be. Then we looked for other ways to confirm our negative results and showed that they were actually negative with other types of strategies, statistical strategies. And we had the help of a colleague who's actually used to do generalized disseminated equations, which of course, explaining the details of the formula is way beyond my capacity, but it's pretty much what Hugo explained. It's a way not to look at one endpoint, like before and after, but when you run the analysis, you have imputation of all the information, all the variability from every single time point where you assessed patients. It's like a very fancy repetitive measure ANOVA in a way. So it helped us to show that the results were also actually negative in using another strategy. So that's one thing. But he ran all the I bothered him so much. He did all the analysis, all the data assessment, he learned a lot concerning statistical analysis, classical statistical analysis. We were very careful, Professor Manuel, to look at, in every single pain tool that we look at, when we talk to Didier Bassira concerning Gen4, the NPSI, everyone is always worried about trigeminal neuralgia because there is a very unique pain where it's extremely painful. I could say that maybe the NPSI has 2 items specifically, maybe designed specifically for this situation, where you ask the patients for paroxysmal pain and you ask for the frequency and how frequent the trains of pain will come. And hello, are you listening?
Number of pain attacks.
Yeah, number of pain attacks, and everything is beyond ideal. The only thing that we could come up with, we have to choose a primary outcome, and even though it was pain the last 24 hours, which obviously does not reflect what's going on with the patient, in the same assessment tool, we have pain information about a longer period of time, such as the last week. So we had secondary outcomes looking at a longer duration of time. So that's important also to pinpoint. And concerning type 1 and type 2, that we were really interested in this information. In the text, we did not classify patients as type 1 or type 2, but we collected on purpose, of course, information on the subclassification concerning presence of continuous pain or only paroxysmal pain. And with the actually with the NPSI, we also have this information besides the NPSI. So we had the NPSI, and we further asked the question whether pain was only paroxysmal or also continuous. And we try to compare patients who had more continuous pain against those who had less continuous pain, more paroxysmal, less paroxysmal. So I agree that it wasn't super clear, like type 1, type 2, and a sub-analysis. This information was in the text. And just a last comment on that, because I love these discussions, Rogério. I'm sorry, I need to talk about it. When you talk about this philosophical, and I have a different view. If you look at the guidelines on the University of São Paulo, they only request that the title and the abstract are in Portuguese and in English. And you can actually write and present the thesis in any language you want. It could have been Mandarin.
I believe they should have been written in both languages, possibly.
No. The abstract and the title, they need to be in English. It's not a choice. They need to be in English. But then everything we're doing here in English could have been in Swahili, if we wanted to speak the language of chikungunya. So that's very interesting. And I personally, I'm right now having the experience of living in a different system where it's a way, the theses are really just very short, just referencing to the publication, but extremely short, even in size, not only in length, and everything in English. And I don't have the impressions people here are forgetting their native language. But I think that it's important to have things in Portuguese, but maybe it needs to be a compromise with internationalization. Same thing with medical visits. That you have medical. I remember Professor Manuel was a pioneer to have the medical visits of the neurosurgery department service in English, like 7 years ago. In the beginning, it was a chaos. Students were all, and after 6 months, it was totally normal. And the quality has skyrocketed. The quality of the English, the quality of the questions, not even from the students, but also from the professors. We got used to it. So, yeah, I have a different view. I just wanted to mention it.
Daniel, there is another point important to make an appointment. The Italian, Spanish, Korean, Japanese universities now are well known around the world because the classes, the publications, the theses are written in English. Doesn't matter the country, you should write in English. But also, what is the problem to have a version in original language? But it's essential to be written in English in all the countries around the world because it's universal language. But it's also important to have a note or a summary in original language. But I agree with you. Are necessary in English. Have people around the world working together with us, and we with the other countries giving some opinion about the method, the results, and so on. Because if you, how many papers in Portuguese we had about the trigeminal neuralgia that the world doesn't know? Hugo made a mention about Portugal Pinto, who wrote papers with Dundee in the United States, but Portugal Pinto described the very important new approach to the trigeminal nerve, personal contributions, very easy, very brilliant results in 40s, 50s, 60s, but in Portuguese. Nobody know about the Portugal Pinto in Federal University of Rio de Janeiro. We know, but even the Brazilian, they don't know, because when they go to the index medicals, no publications about Portugal, Portugal, Ribe Portugal, the Brazilian neurosurgeon from Rio de Janeiro. Very brilliant one. But you don't know this because it was written in Portuguese. Who speaks Portuguese in the world? Brazil, Portugal, Angola, Mozambique, no more. Timor-Leste doesn't exist. But in English, everybody knows at least good morning. Bye-bye.
There are
Obrigado, professor.
a lot of gains, but some losses too when you write a thesis just in English. But in terms, I agree with you, Daniel, that things must go in this way. There are a lot of gains, but since a lot of Portuguese speaking, we're forming professors here in Brazil who will teach in Portuguese. It's a long conversation. But there are gains and losses indeed. And I love very much the Portuguese language, and I think it should be treated in a proper way.
Nice, nice. Thank you. Let's move to the, well, now I'll ask, it's a bit of a mess, but I'll ask not only Hugo, but his fan club to briefly leave the auditorium, the theater. Please don't go further away because our usually takes a few minutes. It's not super long, and then we'll come back to provide you with the results.
A regra na universidade, quando a banca se reúne para atribuir notas ao candidato, as pessoas se ausentam porque é uma coisa privada, depois volta todo mundo. 5 minutos e resolve isso, por favor. Você escrever, a sua letra é boa. Então, se aguarda a foto. Bom, now we should be written some words about the quality of the thesis and about